Hi, I'm Vicky. I'm an MFM trainee working in Hospital Tunku Aziza. Today, I'm going to talk about hypercalcemia in pregnancy. This is a very rare condition. However, it's important to know how to diagnose and manage this condition as it has serious implications on maternal and fetal health. Let me walk you through the content of my talk today. First, I will illustrate the clinical vignette to share some experience in managing these cases in pregnancy. Then we will go through the causes, its implication on pregnancy, the dilemma we have in making the diagnosis, and the challenges in managing such cases. We have a 31-year-old primigravida at 35 weeks. She's got no known medical illness. She presented with complaint of lethargy and bone pain for the past 1 month. There was no other positive history, and physical examination reveals no significant finding as well. Her full blood count, renal profile, liver function test, and thyroid function test were all normal. But what is glaring here is a significantly high corrected calcium level. An ultrasound was ordered. It showed mildly enlarged both thyroid glands, multiple mixed solid cystic nodule, predominantly solid over the left side. There was no definite mass at the posterior of the thyroid gland to suggest an enlarged parathyroid gland. She also had an ultrasound KUB which showed no significant abnormality. She had a serial investigation done which showed persistent hypercalcemia with an elevated intact parathyroid hormone. Her ECG was sinus rhythm with normal QTC interval. Because of the persistent hypercalcemia, she was given subcutaneous calcitonin 400 mg BD for 5 days, followed by vigorous hydration and IV furosemide. Unfortunately, the treatment did not lead to any improvement, and we had to call upon an MDT to decide on further management. A decision was made for delivery in view of hypercalcemia resistant to treatment, and she was already near term at that point of time. The placenta was sent for HPE after delivery. Now, postpartum, her corrected calcium level slowly returned to near normal. So was her intact parathyroid hormone. She was discharged and followed up in the postnatal clinic with renal profile, serum calcium, and albumin level. Her newborn, on the other hand, was brought into the NICU for close observation and noted to be hypocalcemic. Fortunately, there was no tetany and the baby was discharged with treatment. A cyst-MB scan was ordered and it came back as normal. Her placenta HPE was also normal. Her serum calcium and intact parathyroid hormone level rebound subsequently during her postnatal follow-up. And a discussion with local experts, which includes the endocrinologist consultant, was made, and she was planned for parathyroidectomy. While waiting for the surgery, her urine calcium level and calcium creatinine ratio came back to suggest of familial hypocalciuric hypercalcemia. Her genetic testing was done, and the result is still pending. Now let's go through the causes of hypercalcemia. The most common cause of hypercalcemia is primary hyperparathyroidism. It can be due to parathyroid adenoma or malignancy. We should never miss a malignancy in pregnancy. These can be parathyroid cancer, breast cancer, lung cancer, ovarian cancer, or a lymphoma, leukemia, or multiple myeloma. An interesting cause of hypercalcemia here is familial hypocalciuric hypercalcemia, like what our patient had. And another unique cause here is humoral hypercalcemic benignancy. I'll be talking about this in the next slide. Other possible causes for hypercalcemia include hyperthyroidism, vitamin A or D toxicity, acute or chronic renal failure, and granulomatous diseases. Humoral hypercalcemic benignancy is a benign condition where you have high parathyroid-related peptide being secreted by the placenta mammary gland, amnion, dermoid cyst, or fibroma. It is characterized by a suppressed parathyroid hormone. Now, if you have a patient with hypercalcemia, which resolved without treatment after delivery, it is likely that she has humoral hypercalcemic benignancy, as she has high parathyroid-related peptide being secreted mainly by the placenta, the mammary gland, or the amnion. Another condition that is common in hypercalcemia is familial hypocalciuric hypercalcemia. Now, this is a rare autosomal dominant inherited disorder and is characterized by mild to moderate hypercalcemia with low urinary calcium excretion. The patient usually have normal to mildly elevated parathyroid hormone. Many of these patients remain asymptomatic, and therefore we think there are many underdiagnosed cases as well. These patients usually require no treatment, as the problem is just a higher set point for their calcium metabolism. However, their newborn can be unaffected, meaning not carrying any gene, heterozygous, or homozygous. An unaffected newborn will suffer from hypocalcemia, whereas a heterozygous newborn will have temporary hypocalcemia for a short period of time, followed by permanent hypercalcemia due to the underlying FHH. A homozygous newborn will have severe hypercalcemia and need urgent parathyroidectomy to avoid and reduce the risk of life-threatening condition caused by hypercalcemia. Now let's look at this cartoon, which illustrates the normal physiology of calcium metabolism in pregnancy. Now, generally in pregnancy, the fetus has higher calcium level compared to the mother. That is because the fetus needs calcium for bone formation and skeletal development. Calcium from the mother is being transported through the placenta to the fetus, mediated by parathyroid hormone-related peptide. And these peptides are secreted by the placenta. Therefore, in normal pregnancy, the parathyroid hormone-related peptide is elevated. Now, to meet the increased demand of calcium in the fetus, the mother has to have increased calcium as well. So the mother will have increased calcium absorption via the intestine, via her intestine. And in normal pregnancy, there is increased fluid expansion, increased filtration, leading to hypercalcemia and gestational hypoalbuminemia. Now let's look at hypercalcemic patient. The mother has high serum calcium level. And because of this high serum calcium level, there is a negative feedback leading to low parathyroid hormone-related peptide. Now, because of reduction in parathyroid hormone-related peptide, the calcium cannot be transported adequately to the fetus. Therefore, the fetus will suffer from hypocalcemia and transient or permanent hypoparathyroidism. How do these patients usually manifest clinically? A lot of them have no symptoms, or they can have overlapping pregnancy symptoms. Some may complain of bone pain due to abnormal bone remodeling. These patients are also at increased risk of nephrolithiasis. Some of them can complain of abdominal cramps, nausea, ileus, or constipation. Now, there are emerging evidences showing that hypercalcemia can lead to psychiatric issues, namely lethargy, depression, psychosis, or even cognitive dysfunction. Mothers with hypercalcemia in pregnancy are at increased risk of hyperemesis, miscarriage, preterm birth, gestational hypertension or preeclampsia, and depression, while their fetus are at increased risk of fetal growth restriction, prematurity, neonatal hypocalcemia and tetany, and permanent or temporary hypoparathyroidism. Now, diagnosis for hypercalcemia in pregnancy can be really challenging. Many experts are still in dilemma in deciding what is the range of serum calcium level to be used in pregnancy due to the physiological changes in pregnancy, leading to difficulty in interpretation of biochemical results. The main cause for hypercalcemia in pregnancy is still primary hyperparathyroidism. And the recommended diagnostic tool in the non-pregnant population includes high-resolution ultrasound neck, a cis-tummy scan, or a multiple contrast phases CT of the neck. Now, this diagnostic tool sometimes can be, now traditionally, clinicians have reserved in ordering these diagnostic modalities in view of the safety issue in pregnancy. However, nowadays, there are many evidence which shows its safety in the safety of the usage of this diagnostic tool in pregnancy. Another dilemma we have in the diagnosis of hypercalcemia is for the diagnosis of familial hypocalciuric hypercalcemia. Now, because of physiological changes in pregnancy, there can be inaccurate calcium-creatinine ratio and also urine calcium level in pregnancy, therefore making the diagnosis of familial hypocalciuric hypercalcemia more difficult. A high-resolution ultrasound of the neck is safe in pregnancy, and it has a 75 to 90% sensitivity. However, a negative scan requires confirmation with other modalities. What about a cis-tummy scan? It is a gamma-emitting radionucleotide single photon emission tomography. It emits less than 5 milligray. This is way below the threshold level for fetal toxicity and embryo toxicity. It has a 90% sensitivity and close to 100% specificity. And by omitting iodine 1, 2, 3 for early phase, it further reduces the radiation dose to fetal thyroid. Therefore, a cis-tummy scan is actually safe in pregnancy. What about a 4D multiple contrast phase CT scan? It emits 4-fold higher radiation dose than a scintigraphy. Therefore, it is usually not recommended as the first-line tool for diagnosis of primary hyperparathyroidism. But saying that again, sometimes we need to weigh the benefit against the risk when it comes to patients with such indication for the use of a 4D multiple contrast phase CT scan. Now we come to the treatment of hypercalcemia in pregnancy. Hydration and furosemide is commonly used to treat hypercalcemia in pregnancy, and it's definitely safe in pregnancy. But we have to bear in mind vigorous hydration with no proper input-output monitoring can sometimes trigger our pregnant ladies into acute pulmonary edema. Other treatment modalities include calcitonin, cinacalcet, a bisphosphonate, or parathyroidectomy, especially for patients with primary hyperparathyroidism. Calcitonin reduces calcium level by inhibiting bone resorption and increase renal calcium excretion. It has a rapid effect and it does not cross placenta. Therefore, it is safe to be used in pregnancy. Unfortunately, its use is limited by duration, and many patients develop tachyphylaxis after a short period of usage. This leads to a need for the usage of a second line of treatment for hypercalcemia in pregnancy. Cinacalcet is a calcium mimetic agent. It binds to calcium sensing receptor and reduces calcium and intake parathyroid hormone level. It has a delayed onset, and the calcium sensing receptors are found in many tissues, including placenta. Therefore, theoretically, this may affect the neonatal calcium homeostasis. There is still insufficient evidence for its use in pregnancy. It is usually poorly tolerated, and patients often require high dose of antiemetics while they are on cinacalcet. What about bisphosphonate? It is a synthetic non-hydrolyzable pyrophosphate analog. It reduces serum calcium by increased bone resorption. It crosses placenta and retains in skeleton. Therefore, traditionally, clinicians have reserved in using bisphosphonate in pregnancy. However, nowadays, there are emerging evidence which support its use in pregnancy. We think that bisphosphonate is not absolutely contraindicated in pregnancy. However, we need to discuss the benefit and the risk for its use in pregnancy. Parathyroidectomy is the cornerstone and the main treatment for primary hyperparathyroidism. We need to remove the source for the excessive secretion of parathyroid hormone. It is strongly recommended in patients with primary hyperparathyroidism, and ideally it should be done in second trimester. Possible but rare complications include bleeding, infection, and injury to recurrent laryngeal nerve. And in expert hands, these complications rarely occur. There are many papers and many case study and case report which demonstrate the safety of parathyroidectomy in second trimester in pregnancy as the treatment for primary hyperparathyroidism. There are many papers on hypercalcemia during pregnancy in different journals. However, we still lack a proper evidence-based guideline to guide us in management of hypercalcemia in pregnancy. To end my presentation, these are my take-home messages. Hypercalcemia in pregnancy is a rare but very relevant condition as it has serious implications on maternal and fetal health. No doubt there are challenges in diagnosing this condition in pregnancy, mainly due to many patients being asymptomatic or having overlapping pregnancy symptoms, or clinicians having difficulty in interpreting the biochemical tests in pregnancy due to the physiological changes in pregnancy. Scintigraphy is not contraindicated in pregnancy, and a right diagnostic tool is important in diagnosing a condition, especially in primary hyperparathyroidism. Because this condition is rarely seen, especially in pregnancy, therefore, there is definitely a role for multidisciplinary team involvement in the management of hypercalcemia in pregnancy to ensure a favorable outcome for the maternal and fetal condition. Now, always keep in mind, although some treatment modalities may have theoretical rare risk of fetal complication, but we should always prioritize the benefit of treatment to the maternal health. With that, these are my references, and thank you.